Okay, so thank you for inviting me. Sorry about the change of plans. I have two Mesibot Sof Shana to attend very soon, so I'll be gone quickly. Okay, so before I start, my group in the Technion, my lab, the focus is on causal inference and machine learning in healthcare, like the intersection of these three things. And we focus on individual level causal inference, so I was very happy to hear causality come up again and again, and I know following talks will also go back to that. So personalized treatment, okay, we've all heard today about personalized medicine. So I'm focusing on the idea of how can we take data and learn how to personalize treatment per patient. And that is one of the ultimate promises of big data in healthcare. And it's especially important when there are no clear guidelines, right? If there are no clear guidelines, maybe the clinicians need help from us data scientists to do better. And of course, we have vastly more data than in the past. And as we all know, machine learning shines when we have a lot of data. That's where we can best use machine learning. But there's a caveat that most clinical data, which again is where I stand, is observational. So it's collected from hospitals or clinics or by the patients. It's not collected in a randomized trial. It's collected along the way as people behave and are treated in their ordinary lives. And the question of how to best treat a patient, if that's what we want to help physicians with, is a causal question. We need to understand the causal effect of a treatment, and that means that we need to use the tools of causal inference, which is what I'll be talking about today. And just to clarify, say we have a data set of patients from a large hospital, and we have all their lab tests and diagnosis and all kinds of data that we've been hearing about here today. And let's say we want to answer a simple question: who will deteriorate within 1 week? Okay, so that's a standard prediction question, and we could build a predictive model, and I imagine most people here know how to do that. But the question is, if we build this predictive model, what do we do with it? We know who will deteriorate within 1 week, who will not, but that's not quite helpful yet. What we really want to know is why do some people deteriorate quickly versus not? And we also want to know how can we help people? And both of these questions, why and what can we do about it, are causal questions. And causal questions, one way to think about it is being framed in terms of counterfactuals. So we look at a patient and how they were treated, and we say, oh, if they were treated differently, maybe they would have been better, or maybe they would have been worse. And this counterfactual, what would have happened, is one way to define causal effect, in this case on a patient-by-patient level. And the way I frame the problem I'm going to talk about today is just we have a patient, we have her medical record, and let's say we're debating only between two treatments which are currently in use. So we'll call it T equals 0 and T equals 1, T for treatment. And we imagine this patient's two futures. She has two possible futures under T equals 0, under T equals 1, let's say for her blood sugar. And one of the futures might be better than the other. And ideally, we would like to present to the physician, oh, these are the possible futures, make the decision accordingly. Okay, so these Y0, Y1 are called potential outcomes. That's the technical name. And to be a bit more technical, what we are interested in, the quantity, the statistical quantity we're interested in, is something called the CATE, conditional average treatment effect. So the expectation of Y1 minus Y0, condition on X, where X is a vector describing the patient at the time that we are trying to make the decision. So this is CATE is our proxy for the individual level effect, individual for patient X with features X. Now, why is this a problem? Why does this require new methods and new thought? Is we never directly observe CATE. We don't have in our data set anywhere the CATE. For every patient, we only see one of the two features. They were either treated with treatment 1 or with treatment 0. Even if a year later they switch treatment, well, a year has passed. So they are not truly the same patient. They are after one treatment. They have changed in many ways we might not understand. So really, we only ever see one of the two, and that's sometimes known as the fundamental problem of causal inference. And what's worse is if we take our data from a hospital or from a Shalit, for example, the choice which future we got to see for a patient, for Anna, is not random. Someone prescribed to her medication A or B, not randomly, usually. They had their reasons, maybe wrong reasons, maybe they were misled, but they had their reasons. So we not only do we never see this quantity, but that we see kind of one part of it, and the part we get to see is not random and is often biased. Okay, so But let's say we do have, and I'll show this in a second, we have ways to estimate the Kate function with like a bunch of caveats. How do we use this to actually help patients? So the high-level idea is we will estimate Kate hat X for some incoming patient with features X, and then just present recommendations to the doctor. For example, if higher is better, if we want, let's say, a higher Y is better, so Kate X greater than 0 means that treatment 1 will lead to better results than treatment 0, so we will recommend T equals 1. If we estimate Kate hat to be negative, we might recommend T equals 0 for this patient with features X. And if we're not sure, if there's high uncertainty, you might say, we don't know, no recommendation. We're just trying to help the doctor. It's fine to say we don't know. There's no shame about it. Okay? So this Kate, this individual level causal effect, like what would happen under the two different treatments, knowing both futures for a patient, how do you estimate that? So in recent years, there's been a ton of papers about this. Okay, so this is just a small sample, like using all kinds of very cool machine learning methods. I also contributed to this work, often using deep networks. Recently, my kind of methods part of my research is about quantifying uncertainty and estimating Kate, but I will not go into this, okay? Just take it for granted there are many methods to estimate Kate, but they all have a common problem, which is all of these, they rely on what are sometimes called causal assumptions, okay? So they don't work as is. You don't have a true guarantee that they will work. They only work under assumptions which are not always testable, okay? Some of these assumptions are actually provably untestable from data. Okay, so that makes things difficult. Okay, and what I want to talk about here is this framework we're developing for a safe study design. So how do we mitigate these risks of trying to estimate patient-level causal effects, relying on assumptions which we cannot verify? Okay. So the two main challenges are the two main assumptions or conditions are as follows. So the first, and it was mentioned, for example, Dvir talked about confounders. So the first condition is that we have no hidden confounders. So we cannot have any unmeasured factors that affect both treatment and outcome that are missing from our data. So how could this happen? Maybe the treatment was assigned based on unrecorded patient preferences. The patient says, no, I can't stand injections, I prefer pills. Or these side effects are worse for me than the others. And they had this discussion, the clinician and the patient, not recorded anywhere, that might confound our data. Maybe there's some soft criteria such as the level of support the patient has at home, again, which are not recorded in the data. Maybe there's important data like imaging, which the clinician sees, but we don't have access to the imaging data because we couldn't get access to it. All these things could lead to us using the best Kate methods, getting great numbers, and being totally wrong and not knowing about it. Okay, there's no way to test for this. So we can be very wrong without knowing about it, which to me at least, I'm thinking about deploying a system and affecting care is scary. Okay. The other condition is called common support. It means that each patient can plausibly receive each of the two treatments. And when does this not happen? If there's clear guidelines. If they say, oh, this is a patient, this is how they should be treated, these are the guidelines, then for this patient, we will only see, let's say, T equals 0. For patients of this type, we will never see them what happens to them under T equals 1. So we can apply our model and get some prediction, but that prediction will be based on nothing and will be unfounded. Okay? And this is, unlike hidden confounding, this is partially testable, and also we have some work on that recently. So we have this kind of combination of a highly sensitive task, like affecting the treatment of patients, let's say in the hospital, and some hard to verify modeling assumptions. So we focus on scenarios where we believe we can do no harm and maybe do good, hopefully. And we further propose some best practices for actually how to do this step by step, like how to learn the models. And this includes many kind of validation loops. How are we sure that we're doing the right thing? How are we sure that we have good models? And how are we sure that or more confident that these assumptions, including the untestable ones, are probably hold? And the scenario we focus on is something we call clinical point-in-time decision support. And we think this is a type of clinical problem where we think estimating Kate and trying to affect treatment is a plausible thing to do and might lead might help patients. So First, we need a treatment decision that is made by physicians, like by humans, experts, at a well-defined point in time, where the set of possible actions is small, where there are no current clear clinical guidelines, and where there's high variability between physicians. This high variability is what helps us kind of estimate the models. And finally, we need to have well-defined and widely agreed outcomes that everyone agrees we want to optimize this instead of it being very, let's say, idiosyncratic or patient-specific. And if all these 5 conditions hold, we say, okay, maybe you have a chance. You have a chance of building a personalized treatment recommendation tool based on observational data. So I'll skip this. And what we're doing is, so I just said these conditions, but we are developing a best practice pipeline for decision support models, for building these machine learning-based decision support models for this clinical point-in-time case. Okay, so I won't go over all this pipeline, but just a few things. We outline how to have a structured discussion with the clinical stakeholders, just understanding what is it they want. It's not so obvious often. Often, once you go into it, they say, oh, actually, in this case, we don't have any ambiguity, or here, we can't actually affect the decision. So you need to define what is the target system, where will the recommendation system sit, what point in the clinical process will it affect? And that is not necessarily easy to understand. It requires maybe a lot of discussions. After we do that, we have ways of checking these causal conditions, which again, some of them are untestable from data, but doesn't mean you have nothing to do about it. You can talk with clinicians and understand their process. So again, there's this structured discussion component, which is kind of beyond the data. But there's also things that are related to the data, computational tools that we propose how to use based on, for those of you who are familiar with the propensity score and other things. If we're satisfied, so each of these has this exit point, which says, nope, like the problem is too hard, there's hidden confounding, the models suck, we can't estimate this thing, so, better not do this, okay? But assuming we're good, we have ways of building Kate models and evaluating their accuracy and their value. And finally, once we have Kate models, we also have kind of a list of things of how to kind of check them. Okay, so we have a recommendation model. It says this patient should get that. This patient should get that. How do we do sanity tests? There's like a bunch of things you could do to, again, increase your confidence that your computational models are doing no harm and hopefully doing some good. Okay, so full details will be in the forthcoming paper and code. And note that this is flexible with respect to the specific machine learning model you use to estimate the Kate. So I had all these papers from the recent years to estimate Kate. We're kind of agnostic about that. Okay, so in the time I have left, I'll discuss some preliminary results we have. And we'll be talking about the causal effect of diuretics, it's a class of treatments, on kidney function in hospitalized acute heart failure patients with kidney injury in the Rambam Medical Center. Okay, this is our clinical collaborators for this work are Dr. Owen Caspi and Professor Doron Aronson from Technion and Rambam. I want to say we have part of this work, which I will not have time to talk about, was done with Shalit Research Institute looking at diabetic patients. If someone is interested in that, I'm happy to talk about that offline. So what are we talking about? These are hospitalized acute heart failure patients. They are very sick people. A third of them die within a year of hospitalization. And we're focusing on one class of treatments called diuretics and their effect not on heart function, but on kidney function. And the physician tell us they basically have very poor guidance about how to prescribe these medications. They're not sure what to do. Our cohort was about 2,000 patients who had like increase in serum creatinine after hospitalizations, and as usual, we measured a bunch of stuff about them, their demographics, lab tests, diagnosis, and so on. And empirically, about half of them had their diuretics increased or not changed, and about half had their diuretics decreased. So what does this mean? If we call our treatment decreased diuretics, if that's T equals 1, the reason people do this is to improve kidney function, because these patients, their heart problems and the treatment they get for the heart problems hurts the kidney. But it goes the other way, right? In this case, you might improve kidney function but hurt cardiac function. So you need to balance these multiple outcomes for the kidney and the heart, and it's a difficult act. And we are only, for this preliminary study, focusing on the effect on kidney function. Our next step is look at the effect on the cardiac function, which is just a bit more complicated to measure. And one thing I want to, a bit technical about how we evaluate it. So we run our entire pipeline and we see that it's fine and we're happy with all our checkpoints. And eventually, we end up with a Kate-Hat model, which says, oh, for this patient, this will improve cardiac function. For this patient, this will hurt cardiac function. For this patient, we're not sure. We end up with a treatment, what we call a treatment policy. So the algorithm ends up recommending a sort of treatment policy, which is not the same as what doctors are actually doing. It is somewhat different. But for this treatment policy, there's what's called the policy value. People are familiar with reinforcement learning. It's basically the same. It's the average outcome for the kidney function if all patients were treated according to our algorithmic policy or any other policy. So every policy has its value. And it's not straightforward to estimate it, but we can correct it for all these biases. It's still under this kind of star, which says we assume we measured all the causal conditions hold. We still cannot know for sure. There is no guarantee for sure if we're using observational data. So again, the question is whether to increase or decrease diuretics. Policy value, so how good our policy is, or any policy is measured in percent return to baseline in creatinine. Never mind what that exactly means, but 100% is amazing and 0% is pretty bad. And we fit our model, did all our stuff, had our held out set, and then we evaluate the policy on the held out set at 530 patients, for which we had recommendations for 461. So for 69 patients, we're like, our model was not sure, so do as you please, we have no recommendation. And our confidence intervals are by bootstrap. And here's the first policy value. What if we just increase diuretics to everyone? So we get policy value of about 25%. This is the policy value of what actually happens, okay? This is the way patients are currently treated by the doctors. So here we actually have no ambiguity because this is what actually happens. There are no counterfactuals here, okay? So this is slightly better than increasing for everyone. This is a random policy, okay? So as you see, it's about as good as the doctor's policy. When I saw this, I thought we had a bug. And then we talked with the physicians, and they were like, no, we believe this might be true, actually. We have no idea what we're doing, which is, yeah, sad. This is what happens if you decrease to everyone, so slightly better. But again, remember that there's these trade-offs of where doctors are not only optimizing for renal function. And this is our machine learning policy, our algorithm. So we can show that our recommendations are better than current practice. The P is 0.015. But it is approximately the same as just decreased diuretics for everyone. However, our policy, if we kind of look into it, it decreases diuretics for only half the patients. Okay? So this allows more flexibility with respect to the other outcomes. Again, there's a reason doctors don't just decrease to everyone, because they want to optimize also the cardiac function. So again, this is our next step, looking at the effect on other outcomes, but at least we're doing not worse than anything else, and we're offering more flexibility to the physicians. Now, we have these reasonably good results, but should we believe this? And note that we don't really know what would have happened in the cases that did not follow our recommendation, right? Our recommendations obviously differ from the doctors because we have a different policy value. So we can't know for sure if this patient were treated different, what would happen to them. Our model says this is what would happen, but our model might be wrong or confounded. And the only way to truly know if our personalized recommendations are useful is to run an experiment in the hospital in front of real clinicians and real patients and giving them recommendations and see if recommending a treatment actually leads to better outcomes for the patients. And eventually we'll get there, but we have kind of a high bar. We want to convince ourselves that we're not doing any harm before we're actually affecting treatment of patients in the hospital. Okay, so just thanks to the people who did this work. So there's Rom Gutman over there from the Technion, Shimon Shaiba from the Technion in Gonzales, Dr. Oron Kaspi, Professor Doron Aronson, and the folks at Elite Research Institute, who again, I did not show our results, but we also have results from there. Thank you very much, everyone, for your time, and I'm happy to take any questions.
Thank you.